She has coordinated psychiatric and psychological services for adults with IDD and autism, living in community group homes, and supported living arrangements through West Bay Residential Services Incorporated. Throughout her career, Dr. Wilson has practiced from a behavior analytic framework while providing clinical supports to individuals with dual diagnosis who exhibit challenging behaviors. And she is also an adjunct instructor of psychology at the Community College of Rhode Island, correct?
Yep.
And for the past 6 years has been an instructor and thesis reviewer in the Kaplan University Applied Behavior Analysis Master's Program. And we did have a last minute topic change, and she's going to be presenting a 4-stage model for behavioral intervention in people with intellectual and developmental disabilities and psychiatric diagnoses. All right, Dr. Wilson, you may take it away.
So thank you. Thank you for having me here tonight. And what I'd like to talk about is a 4-stage model for behavioral intervention in people with intellectual and developmental disabilities and psychiatric diagnoses. So it's kind of a mouthful. Originally, I had hoped to talk about a trauma-informed approach to applied behavior analysis, which I'm really digging into lately, but I found that I just wasn't there yet where I could competently present a well put together presentation. So thank you for tolerating the last minute topic change. So the name of this presentation is a 4-stage model, etc., for behavioral intervention in people with intellectual developmental disabilities and psychiatric diagnoses. This is a tool that I developed quite some time ago and that I've been using with pretty good effectiveness over the years. And actually, I really could call this a 4-stage model for behavioral intervention in people. Because, you know, what I've learned over the years is that although I developed this originally, and I'll tell you a little bit about the person that inspired me when we get to a case study down the line, I developed this originally to create a vehicle to provide behavior analytic services and other services, and integrate that with other services that people with developmental disabilities and very severe psychiatric challenges were experiencing. What I've learned since then is that I can really use this model to frame the services I provide to just about anybody. And I've used this, you know, to this day I use it very frequently. And the use of this with people with psychiatric diagnoses was really just the roots of it. And I've really developed a lot since then. I've developed the use of the model a lot since then. So let's just start and talk about, first of all, let me outline what I'll talk about in the next little while. I'll talk a little bit about the theoretical background for the model, what I believe are prerequisite conditions for the use of the model. I'll go on to describe the model. How I use the model to develop interventions and how I do training with the model. This model is really about organizing and training treatment programs. And I'll present some case studies. So let me tell you a little bit about what I do. I work at West Bay Residential Services Incorporated in Warwick, Rhode Island. This is a fairly large agency that provides residential and vocational services in the community to in about 30 plus homes and apartments. In addition, we have about 30 supported living and self-directed programs where people are living in the community, in families with friends, who they're using their funding to choose who they want to live with, and self-directing their own programs. So I think now, I walked around my office this morning asking everyone from the executive director to the accountant, the lead accountant, how many people that we are supporting now. And we came up with about 150. So I don't think there's no one could put their hands on an official roster, but we're supporting about 150 people right now. And these folks exhibit the full range of IDD and autism. Many of them also have multiple physical disabilities. West Bay first opened back in, I think, 1985, as the major state institution was shutting down under court order. And people were coming out of that institution to live in the community. So we opened with just a couple of group homes. I wasn't around then. I came along later on in 1997. And so the folks were coming out of the institution at that time. And as time has gone on, and we really developed actually a specialization in providing services to people with multiple physical disabilities that might otherwise have had to be in nursing homes. So that was kind of the direction in which we were developing over the years. And in more recent years, these folks, grew up and grew old and became elders, and many of them have passed along in the last few years. And we're getting a lot of young folks coming in, a lot of people coming in from children's services. And a lot of people in Rhode Island are going into these self-directed or supported living programs, people that don't have terribly complex challenges. So the folks that are being referred to our system do tend to arrive with some pretty complex situations. In the past year, I want to say that I have met most of my referrals in psychiatric hospitals where they've experienced long-term placement before they came to live with us. So just some background on the kind of people that I'm working with. And we do provide services to people ages about 18 or 21, usually 21, but there are occasional youngsters. And we actually have a lady who is, I believe she just turned 104 living in one of our group homes. So, and she's just a lovely, dignified, wonderful woman. So our group homes are in the community. Here's a picture of one of them. Our goal is to integrate in the community, to not stand out, to look like any other house, any other well-kept house in the community. And about 35%, if not a little bit more at this point, I would really have to take a step back and look at that and maybe update that number, of the individuals that I'm supporting are currently being treated for a psychiatric disorder other than their developmental disability or autism. So that's kind of the picture of who we're providing services to. So having been in this field and working with this population and working at this particular agency for 21 years now, going on 21 years now, I would say that what we actually have gotten good at is, really recognizing the existence of mental illness in people with IDD and autism. People with IDD and autism do exhibit the full range of psychiatric disorders that anyone else does, and probably at a little bit higher prevalence than people in the typical population for a number of reasons, which is another whole presentation. We've also learned to identify psychiatric symptoms based on non-traditional patterns of presentation in people with IDD and autism. So folks that I support who are diagnosed with depression or generalized anxiety disorder or bipolar disorder, any of these disorders, don't necessarily have present symptoms that look like DSM-5 presentation. And a lot of this has to do with the fact that many people that I'm working with are not terribly verbal, and a lot of diagnosis in DSM-5 is based on people being verbal and expressing what's going on with them. So we've learned to look for other behavioral things that might indicate the existence of a psychiatric disorder, and sometimes it's really a clinical diagnosis when we treat people for that disorder and they get better. We've also gotten good at identifying and using effective behavioral, psychosocial, and psychopharmacological treatment for people identified with IDD, autism, and mental illness. And I have to say that I have really personally seen a lot of growth in this area in the time that I've been working with these folks. But here's the problem that I run into, or that I still run into it, but it's what kind of inspired me to develop this model and what this model has helped me with. And again, it goes back to this woman that I'll tell you about later. How do we create a context within which behavioral manifestations of psychiatric disorders can be identified as symptoms and addressed with established forms of intervention, including behaviorally and psychiatrically grounded interventions? I think, and I still see this, maybe it's getting a little bit better. I do my best to make it get better. There are some really unhelpful assumptions that have been created based on a dichotomous, and it's really a false dichotomy, I think, either or view of symptoms and treatment. So I think a lot of people believe that behavior is either learned, volitional and predictable. In other words, people choose to act out in ways that are, aggressive or disruptive. Best treated by manipulating environmental variables. That behaviorally based techniques are the most appropriate treatments to use. And that the best person to treat these behaviors is the psychologist or the behaviorist or the behavior analyst. And then there's the other side of behaviors that people believe are biologically based, internally driven, unpredictable, not under individual control, that are treated by manipulation of internal variables, which typically means medication, and best treated by a psychiatrist or a doctor. So what I've come to see is that this is not at all a helpful way of looking at behavioral symptoms, whether they be learned or whether they be biologically based, and that we really have to kind of integrate our understandings of the origins of behavior if we're going to come up with really effective treatment programs, especially when we're providing treatment programs to people with extremely challenging behaviors or, you know, with psychiatric disorders that express a lot of symptoms associated with that psychiatric disorder. So a more helpful approach is going to focus on how individual factors combine to create these patterns of symptom expression. There's an extra word there, sorry. So I've come to understand psychiatric disorders as establishing operations for some problems considered behavioral. Let's do a few references in here for you to take a look at if you'd like. The reference list is going to be at the end. So Baker and Bloomberg in 2006 talked about psychiatric disorders as establishing operations for as establishing operations for some of the behaviors that we see. And this is a really good way, I think, to frame or to approach treating people with psychiatric disorders from a behavior analytic point of view. So establishing operations, as you know, change the way, sometimes only temporarily, that the individual responds to environmental contingencies. So in terms of psychiatric disorders, we can think about the relationship between depression and reinforcement. So someone who is exhibiting symptoms of depression, who is experiencing depression, may not respond to environmental contingencies of reinforcement and punishment in the same way that someone who doesn't have depression might respond. So I've really been delving into establishing operations lately, and actually more in connection with my research into trauma-informed approaches and behavior analysis. But if you go back to the classic articles published by Michael in 1982 and 1988, real good review and analysis of establishing operations and how they can change the way that people respond to environmental contingencies, and how that this can help to account for some of the responses that we see associated with psychiatric disorders in people. So if we take this view, we can still hold on to our belief that within the individual, behavior is predictable regardless of etiology. We just need to study each individual regardless of the etiology of their symptom expression and learn what they look like as they move through the different behaviors that they're moving through. And then what I've come to understand is that we can utilize the predictability of behavior to plan effective behavioral and psychiatric interventions for people with developmental disabilities and mental illness. Okay, so the four-stage model that I'm going to present very shortly is a tool for identifying individual patterns of symptom expression and prescribing effective interventions at appropriate times. It's not a treatment, it's a vehicle for organizing and training. So there are going to be some prerequisite conditions that need to be met before you can use the model. You need to have your treatment plan already created before you can use the model. And there are some other prerequisite conditions that I'll talk about in just a moment. So I have found, and what I hope to share, is that the model is equally appropriate for behaviors which are identified as learned, associated with a psychiatric syndrome, multi-determined, or even of unclear origin. So that's kind of cool when you think about it, that we can begin to affect some change in people by using this model, even if we are not 100% sure of what is going on. So what are the prerequisite conditions for use of the model? First of all, I'm a behavior analyst, so I'm going to do a full functional assessment. It's always going to be the first thing that I do when I meet a person and I begin to assess a person and get ready to create a behavioral intervention. At the same time, if the person is exhibiting symptoms of a psychiatric disorder, we also want to have an accurate diagnosis of psychiatric conditions, and I'm lucky enough that I have developed some really close working relationships with some really amazing psychiatrists. And we collaborate really, really well to integrate our treatment plans together. I use my behavioral monitoring techniques, my data collection, to assess whether or not we're seeing change in the person when there's when psychiatric intervention is implemented, medication, etc. And the psychiatrists I work with use my behavioral data to help inform the decisions that they make. So that's wonderful, and that also is another whole presentation that I enjoy giving. Okay, of course, we need to rule out and treat medical problems. I mean, so many times in my experience, the behavioral, the behaviors that I have seen being expressed in people have been due to things like thyroid disorder, urinary tract infections. I've had a couple of people who, one man, as an example, with Down syndrome, who always had some tendency towards occasional episodes of aggression, but very occasional, like maybe a few times a year. And over the years, he got better and better, actually, in the time that I knew him. And all of a sudden, his behavioral expression just completely changed. He became very aggressive, self-injurious, uncooperative with self-care, couldn't cut his hair, his beard grew, he looked messy. Well, did a bunch of medical testing, and it turned out he had celiac disease. And when he got on the gluten-free diet, he got better without a behavior support plan or psychiatric intervention. So, of course, if the behavior that we're seeing is stemming from a medical problem, we want to identify that and treat that, and not use a behavior support plan to treat a medical problem. But we do want to get the appropriate behavioral treatment plan in place when our functional assessment indicates that that's what we need to do. If our psychiatric evaluation by the psychiatrist indicates that medication is appropriate, we want to get that into place. And sometimes other therapeutic interventions are helpful. I have a lot of folks that go, that use counseling very successfully, talk therapy, learn a lot of coping techniques that we can kind of build into their behavior support plans as well. So we want to get that in place as well. And these last two things, maybe they're the toughest. The first 1, 2, 3, 4, 5, the first 6 things I have a lot of control over. The last 2 are less in my control, so it can be more challenging. The availability of high quality ongoing training and support for direct support staff. We really need the frontline people to be on board, to be understanding what we're trying to achieve and how we're trying to achieve it. And the model helps with that, and you'll see why, I think, momentarily. And I think most importantly, strong administrative and management support, so that I've got the backup, the administrative backup. I work as a consultant, in a consultant role at my agency. So I have no direct supervisory power over anybody. I have to rely on my administration and the managers to help make implementation happen after I've done the development and training. Okay. So this is the actual, what I call the 4-stage template. So we have 4 stages, and every stage has a name, every stage has a goal, every stage has a set of behaviors that we identify for the individual, and every stage has an intervention that's appropriate for that stage. So I played around with different names for the stages over the years, and this is what I've mostly settled with now. Is in stage 1 I call optimal function. So this is the person just having a good life, just enjoying their life, having meaningful relationships, everything we want for the folks that we support. So our goal here is to stay in stage 1. I'll come back to behavior and intervention in a minute, I think. Stage 2, we start to see either antecedents, which suggest to us that we may see some behavioral escalation, or precursors being exhibited by the individual that indicate that that individual is starting to go through some behavioral escalation. Our goal here is going to be to move back to stage 1. And as I always tell the staff when I'm training them, if we can't move back to stage 1, at least we don't want to move to stage 3. And I do know a lot of people that spend a lot of time living in stage 2. Stage 2 is tricky. Stage 2 is really tricky. It's really important, as I teach people, to do the right thing at the right time to address the behaviors with the appropriate intervention at the right time. And in stage 2, if we make a mistake, we didn't do just the wrong thing, we can knock that person right into stage 3 the acting out stage. So stage 3, the acting out stage, is wherever that big, bad, ugly thing that you didn't want to see is happening. And of course, that's usually aggression, self-injurious behavior, environmental disruption, or some combination of all of those things. So our goal here is to move on to resolution, which is the calming stage. In stage 4, resolution, our goal is going to be to move back to stage 1. Now, what I always emphasize is that this is this model is what this model looks like for each individual is completely individualized. It's completely based on how that individual presents as they move through these stages. So let's go back to stage 1, optimal function. I think you'll see this better on another slide. I meant to upload another slide which shows the questions that I ask as prompts when we put together this template. In stage 1, first of all, I ask, in a moment I'll explain how this is a collaborative process. In stage 1, I ask, what does this person look like when things are going well, when they're in optimal function? And we identify all the behaviors that we expect to see when things are going really well for this individual. Then I ask, what do we need to do in order to maintain this person in stage 1? So I use these questions as prompts when I'm working with people to develop this model. So in stage 2, I ask, what are the behaviors that we have learned by knowing this individual and observing this individual? What are the behaviors that indicate to us that this individual may be escalating and that we may need to do something to prevent them from moving into stage 3? And then in terms of intervention, what can we do that will help to de-escalate the individual? How can we turn the situation around? That's the question I always ask. How can we turn this situation around and get this person back to stage 1? Stage 3, the acting out stage, well, here, as I said, this is the stage where there's not a heck of a lot that you can do. I think that stages 1 and 2 are very work intensive, and hopefully stage 1 is where staff and the people supporting people are spending most of their intervention time. Really, the more work that you can put in on the stage 1 end, the less you'll have to put on later on in stage 2 and stage 3. But when we get to stage 3, the individual has reached a place where we can't effectively really interact with them anymore. And our intervention is going to somehow focus on just keeping them safe at this point. And I'll explain that further as we go along. Sometimes we just have to get through stage 3 safely and keeping everybody safe. So what we identify here is, what behaviors are you observing that tell you that this individual has now moved into stage 3 and that our stage 1 and 2 interventions are no longer appropriate. And then stage 3 will end eventually, and hopefully everyone will be safe with the interventions that we have in place. We'll move into stage 4, the resolution, the calming stage. And the question we ask is, how can we support this person through the calming stage? What does this person need in order to help them calm down? So if we look at this slide here, this is kind of some general parameters that kind of define each of the stages. So in stage 1, typically the individual is emotionally stable, engaged in activity, relaxed, focused, productive, having fun. This is very general. This isn't any particular individual. So our intervention is going to focus pretty much on supporting the individual with quality activities, proactive positive behavior support strategies. We teach coping skills in stage 1 and have people practice them so that they can access them later on in stage 2 when they need them in order to help themselves de-escalate. We are using strategies that are tailored to the individual and the individual's likes and needs. Intervention is intensive, educative, and preventative. As I say, I really think we are best off if most of our treatment effort can go into stage 1. Now in stage 2, we start to see the individual displaying characteristic behavior patterns that are antecedent to more severe forms of acting out. So we're looking for changes in mood, in affect, in facial expression, in body language, and verbalizations. And our intervention is to initiate activities to redirect back to stage 1 and then reinforce stage 1 behaviors once we've been able to do that. In stage 2, we're focusing on problem solving, distracting, soothing, relaxing, and avoiding further escalation. Now remember that it's important that we've been teaching these strategies, or that we've been practicing these strategies rather back in stage 1, so that they will be available for the person to access in stage 2. In stage 3, the acting out stage, typically the individual is engaging in aggressive or disruptive behavior. They're not communicating effectively. They're not responsive to directions or guidance. As I said before, the focus is on safety. We're monitoring closely. Intervention is really minimal. Interaction is definitely minimal. We probably are going to discontinue attempts at rationalizing or verbalizing. We may do, brief verbal directives, please go sit in that chair, please sit on this mat, that kind of thing. But beyond that, we're probably not going to be, trying to reason with people or interact verbally with them. As I said, this is individualized. So the intervention here, what exactly we're doing to keep people safe, is going to be different from individual to individual to individual. We may be bringing out a mat for them to sit on. We may be putting a pillow under their head because they're banging their head on the floor. This may be a time when some physical intervention is also required. But whatever is required during this stage is going to be individualized for that person and planned in advance, so that when the time comes, we know exactly what we need to do. And most importantly, we're watching for signs of resolution at this point. We're watching for signs that they're calming. So once we start to see those signs, the individual is calming, ready to interact, responsive to directions. In most cases, we want to test it out a little bit, and I'll show you some examples of real plans where you'll see how we do that. And we're going to gradually reintroduce stage 1 activities. And everybody's different. Some people can go through a stage 3 episode, and they are ready to get, when it's over, and they're ready to get on with their routine and get right back into their stage 1 activities. Some people, we want to be a little bit more careful, keep our eye open for re-escalation. We might want to, interact guardedly for some period of time, an hour, 2 hours. For some people, sometimes we need to be on our guard for a couple of days, depending on their own characteristic expression of these behaviors. But we're watching for re-escalation. If that happens, we're moving back to stage 3, but ultimately our goal is to move back to stage 1. Okay, so that is the general presentation of the model without any, not directed towards any specific individual. All right, now I'd like to go on to talk about how we use this model in order to help staffs plan interventions. And remember, it's intended to be a collaborative process. I'll share some examples. Okay, so this is what it looks like. I come into a staff meeting and I have kept an overhead projector around, and I like using the overhead projector. It's messy, it's fun. I will use the laptop and project up on a screen as well. So that template that I just showed you with nothing written in it except the goals, the behaviors, and the interventions, and those prompting questions when I'm working with staffs are in there. And I'll be in a room with 15, 20 people, the staff of a particular house. I go over what the model means, what each stage means, and then I ask them to describe the individual, what their behaviors look like through each stage, and then what interventions are helpful supports for them as they go through each stage. Now remember, I also know these individuals pretty well, the people that we're doing the model on, but I know there's so much collective wisdom in the room from the direct support staff, from the frontline staff that are working so closely with these folks day in and day out, that they are often quite on target with what the behavioral expression looks like and what is helpful for the person as they move through these stages. So it's chaotic and it's fun. They yell things out. I try and capture what they're saying. This is up on a PowerPoint projector. I've got my Sharpie marker and I'm writing down, I'm saying, just yell it out, just yell it out. I've got my back to them and I'm just writing things down as they're shouting them out. And by the time we're done, it's a big mess. And I facilitate and I tweak a little bit, but I find I don't have to that much because, as I said, with the collective wisdom of these staffs in the room, they really do a pretty good job. And then I leave the meeting, we go through what they came up with, we tweak it a little bit, we see what makes sense to keep in, what doesn't make sense to keep in. I walk away with this, and within a couple of days, I come back to them with a nice, pretty plan, which you'll see in a minute. So This is Miss F, who I met way back when. She is the person who inspired me to create this program. She was 50 years old. I actually think she was 48 years old when I met her. She was hospitalized at a psychiatric institution. She had a long history of multiple institutionalizations and hospitalizations. She had a long history of having been abused in multiple settings, in her family, in foster homes, in the hospital. It was just a very, very sad story. She had cerebral palsy. She didn't walk. Communication was difficult. She had depression, diagnosis of borderline personality disorder. She had intense tantrums that lasted from 1 to 8 hours, that included severe aggression and severe self-abuse. When I met her in the psychiatric hospital, she had been in there for some time. They could not find a placement for her, and she was about to go to a long-term institution where she probably would not have left. My executive director at the time caught wind that she was there. He grabbed me, we went down, and she came home with us. And then things got crazy. She was wonderful when we met her. She said she really wanted a home, and could she come live with us? And I remember it was so awful. There was a social worker sitting in the meeting with us, and the social worker was telling her that she had behaved so poorly, she didn't deserve a nice home with nice people like us. So if you knew my executive director at that time, you would know that he would be even more determined to take her with us. So we did. We brought her home, and she moved into one of our group homes, and very shortly thereafter, chaos just ensued. She was having these incredible tantrums. She was hurting herself. She was hurting other people. And she had a lot of energy, amazingly. These tantrums could last forever. And I was writing the behavior support plan, and I was trying to get it in place, but there was so much chaos. And, if you've ever provided services or supports to someone with borderline personality disorder, there's a lot that goes on around that, with staff splitting and the emotions of the staff around this. And I just couldn't bring the staff together to provide good services to this lady. And an administrator said to me, isn't there some way you can come up with some way to organize the behavior support plan and get everybody on board with it? And I won't tell you the whole story because I know we're a little short of time, but after tossing this around for a while, we did a lot of things with this staff to try to get them to come together as a team. And we finally did, with all the different things that we did. And we came up with this I came up with this 4-stage template and put the behavior support, used that to frame the behavior support plan with the help of the staff. And it really brought the staff together as a team. And we held like a day-long conference for the staff at that time. We had them sign contracts that they were committed to the program. We did all kinds of cool things. And we worked with them to create this template. So this is Miss F in her 4-stage format. We identified what she looked like when she was doing well, when she was escalating, when she was acting out, and when she was calming. With Ms. F, we focus a lot on learning and practicing coping and relaxation skills, on getting her to focus on the present and the future. She had a self-monitoring checkoff system where she earned checks. She was using a journal to record problems that she could take to her psychiatrist with her. We taught staff how to do empathetic listening and validate what she said. We kept her busy and productive. We taught them how to avoid splitting, and we talked about making the plan. So the plan was Ms. F learning and practicing what she would do if she started to escalate. So we get into stage 2, and we would start these coping strategies. There was a psychiatric intervention. There was a PRN in place, so that would come in stage 2. So you can kind of look this over without me going through the whole thing. But we got everything into place that Ms. F needed as she moved through these stages of escalation. Okay, so here's some data for Ms. F. I don't have data for everyone I'm showing you tonight, but I do for Ms. F. I actually published this as a case study back when. So this is the mean frequency per day of episodes at baseline and at post-treatment intervals of 1, 2, 6, and 10 months. Now remember that at baseline, the behavior support plan was in place. It was the 4-stage model that was not in place. So I broke her episodes down in terms of operational definition to major episodes and minor episodes. The episodes involved screaming, self-injurious behavior, aggression, biting self, biting others. Major episodes were defined, the biggest definer of the major episodes was that she would undo the seatbelt on her wheelchair, slide to the ground, and lay on the ground, blocking the path of everybody while engaging in all those other things that I'm talking about. minor episodes, maybe she would become kind of whiny. She would have some aggressive verbalizations, but she wouldn't leave her wheelchair, and it wouldn't get quite as intense. So I defined those operational definitions. So notice that at baseline we had 0.34 per day for all episodes. Majors were 0.19 per day, minors were 0.15 per day. 1 month following treatment, we're still at 0.39 per day for all episodes, but notice that majors have gone down to 0.10, and interestingly, minors have gone up to 0.29. 2 months following treatment, we have a bit of a spike, and I don't know exactly what accounts for that, but I find it really interesting that majors go down to 0.06 per day and minors go up to 0.39 per day. So even though we're having a spike, that spike is in minor episodes, not major episodes. At 6 months, we're down to 0.23 per day overall, so that's some fabulous progress. 0.10 majors, 0.13 minors, and then at 10 months following treatment, we have 0.13 per day, 0.03 minors, and 0.10 majors. So really, I think some really exciting progress that Ms. F exhibited over that 10 months. And this is the same data presented graphically, with the top line being all episodes, the pink line being majors, and the blue line being minors. And I think it's really interesting that the blue line runs kind of parallel to the all episodes line. So the end of that story is that Ms. F developed more and more over the years. She ended up living a very high quality life, developing wonderful relationships with people. She would once in a while cycle back into a period where she would exhibit some of these behaviors, and I would work with the staff, kind of gather things up, gather things in, pull the staff together, get everything back on track. But eventually, she really was hardly even a blip on my radar screen anymore. And she was around for a long time. And actually, she passed away about a year ago of natural causes, surrounded by many, many people who grew to love her over the years. So from my point of view, it's just a wonderful success story. Okay, so I have 2 other case studies here, and I see we're 2 minutes before the hour here. So I just wanted to show you other people, and I've used this with scores of people by now, but just different types of people. So Ms. D, being a woman in her mid-20s with a mild intellectual disability, history of abuse, also with a psychiatric disorder, personality disorder. I find this model really useful when there's a personality disorder on board. So won't go through it, but set up the same kind of thing. This woman was using a self-monitoring checklist with reinforcement for completing her checklist and meeting her expectations over the course of a day. And she actually was able to move out of her group home and into a supported living arrangement. She still attends our day program, so I'm in touch with her, but her behavior program has actually, from my end, been discontinued. She's doing so well. And Ms.
Dr. Wilson,
yep.
I just wanted to let you know, you are more than welcome to continue another 10 minutes, because I do believe we need to meet a minimum number of minutes for our CEU.
I think that's true. Okay. All right, so I'll slow down. Thank you. Okay, so, and Ms. H. So this was an older lady with severe DD. She also had paranoid schizophrenia. She was living in a house with one woman. She actually was in the institution until 1986. She had a lot of very institutional patterns. She was verbal and interactive. She was kind of a cool person to work with. She had a diagnosis of paranoid schizophrenia, organic personality disorder. We would see aggression from her, environmental destruction, temper tantrums. She was also being treated psychiatrically with Zyprexa and Tegretol. So I don't have data for either Ms. D or Ms. H. I mean, I do have it, but I didn't upload it for this presentation because there was already so much here. But so this is what Ms. H's 4-stage format looked like, that again, I developed with her residential team. So we knew that she was doing great when she was active, engaged, talkative, friendly, eating well. That was an important sign that Ms. H was doing well. She would refuse to eat when things were going poorly for her. Busy, productive, cooperating, talking about quote unquote real things. She did have a diagnosis of paranoid schizophrenia, so we would see some symptoms around that. So we supported her with social reinforcement, natural praise for appropriate behaviors, Consistency, structure, routine were very important to her. A positive, upbeat environment was important. So, we're able to build all of this into this template. She was a smoker, and she had a cigarette and a coffee routine. So following that routine was really, really important. Her cigarettes and her coffees were paced through the day, and that was very helpful for her. That helped keep her on track. And she earned quarters for meeting her expectations and not engaging in her target behaviors. So that worked really well for her. In stage 2, we would see she would start to mumble. We'd see excessive perseveration or obsessing about things, throwing away her food, stealing soda and coffee. She would get really mean in stage 2. Like we would teach people not to talk to her about personal things in their personal lives, because she would say really mean things, like, yeah, I'm going to come to your house and kill your dog, or, so that was part of her escalation if we saw that kind of mean behavior. So it would often be helpful in stage 2 just to remind her to stay in control, that she was earning quarters, to not get into negative verbal exchanges with her. We definitely wanted to avoid physical contact with her, to stay firm, directive, and neutral. So you see, with this model, we're giving staff not only the behavior support plan and how that's being implemented, and the contingencies of reinforcement and all that kind of thing, but we're also giving them what the environment needs to look like, what their interactional style needs to look like, and we're doing it all on one page, which is, to me, one of the best things about this. I don't know what your behavior support plans look like, but mine can be, like a dozen pages long. The first 4 or 5 pages, sometimes just having regulatory information that the staff don't even need, that just has to be there by law as part of my behavior support plan. And the staff have to kind of shovel through that before they can even get to the actual guidelines and the actual treatment plan. So this template takes that and condenses it to one page. But again, it's in addition to the behavior support plan. It's an adjunct to it. The behavior support plan is already there and is already in place before we take this and use it to frame that. So Ms. H would get into her stage 3 acting out behaviors, the screaming, the threatening, the throwing, the aggression. We taught staff to stay firm and neutral, to cue her that we'll discuss this when you calm down. And here is a time when we might use some short directives. We used to use a lot of gesturals with Ms. H. We would, let her know that she needed to go to a safe area, and it might be a chair at the other end of the room, but gestural prompts would be helpful for Ms. H. So we taught staff to do that during stage 3, to point to the safe area. Monitor from a safe distance. Don't attempt to talk or interact. If she comes out of the safe area, redirect, and, avoiding meds, coffee, cigarettes. Unfortunately, in Ms. H's past in the institution, and this was true of a lot of people that I knew that came out of the institution, things like cigarettes and coffee were used to get people to calm down when they were engaging in this kind of behavior. So there were some unfortunate behavioral patterns we saw around those things. They were also unfortunately used to manipulate people. Their really addictions to cigarettes and coffee were used to manipulate them in ways that weren't ethical. So I think Ms. H had that kind of past that she brought with her. So Ms. H would calm down, and we knew she was calm when we would see a few minutes of quiet. Sometimes it took her up to an hour to calm. Once she would start, we would always say, once she started, she would need to finish. Ms. H needed to completely vent. She wasn't done until she was done. And then we would test her out, ask her to engage in a simple activity, to set the table, to take a walk, to color. And if cooperative, go back to stage 1. If not, we knew we were in stage 3 for a little bit longer. So 3 different people with 3 different types of plans that all worked with this format. And since then, I've used this format with so many, different folks of people with different types of challenges. Between you and me, I have even helped staff develop a 4-stage plan to help them interact with and deal with families that were challenging. And that has also been successful, so that they would learn what the family member looked like as they were escalating, and the best ways to interact with the family member in order to avoid really control issues, power struggles, and to, help de-escalate the family member to keep everything peaceful for everybody. And I've been really successful with that as well. And as I said, I've come to believe that this format is effective for any individual, child, adult, psychiatric disorder, completely, learned behavioral challenges that, for me, it's always been effective for just about everyone I've used it with. So in terms of conclusions, what I've learned and what I believe is that within each individual, behavior is predictable regardless of etiology. Behavior can look very unpredictable when you're working with someone with a psychiatric disorder, particularly if you're working with someone with a personality disorder. Behavior can appear to be very unpredictable. This model kind of helped me to learn that behavior is predictable and helped me to frame what behavior looks like so that I could teach other people that behavior is predictable and what behavior looks like as people move through different stages. So we can use the predictability of behavior to plan effective behavioral and psychiatric interventions for people with DD and mental illness. Psychiatric disorders, as I've said, are behavioral setting events, are probably really more motivational operations for problems considered behavioral. As I said earlier, psychiatric disorders do change the way the individual responds to environmental contingencies. I gave the example of depression and reinforcement, for instance. And I think treatment has to take this into account if we're going to provide effective treatment and produce effective behavior change. So that's the 4-stage model. It's a tool for identifying individual patterns of symptom presentation, prescribing effective interventions at appropriate times, and perhaps this is the number one, the biggest value of this tool for me, and achieving collaboration and investment from frontline staff. I mean, I've really been able to develop some wonderful collaborative relationships with the staffs of the individual group homes that I'm working with, and they really do end up feeling invested in the treatment plans that we create. And plus, they're an excellent training tool when new staff come on board. I don't know if I've said that before. When new staff come on board, they're an excellent training tool to, very quickly introduce the new staff to the behavior, to the treatment plan, in addition to having them read the very long, cumbersome behavior support plan. So, as I said, the model is equally effective for behaviors which are identified as learned, which are associated with a psychiatric syndrome, which are multi-determined, and in some cases are even of unclear origin, while we continue with our functional assessment and functional analysis to try to come to a more clear determination about where the behavior is coming from. We can at least begin to contain what's going on by framing it in this model. Some references there if you're interested. I do refer to myself down here, the 4-stage model for behavioral intervention in people with mental retardation and borderline personality disorder. Unfortunately, we were still saying mental retardation back in 2001, and there's no way to go back and edit that. And it's funny, it just goes to show you that you can't necessarily predict how things are going to change. I believed that I was using person-first language back then because I said in people with, so, and we've come far from that. I've got those 2 articles by Michael, which are classic articles on establishing operations and motivation. Particularly, I think that 1982 article is just really enlightening. And the Baker and Bloomberg article on functional assessment and mental illness, an interdisciplinary approach to intervention, published in the National Association for Dual Diagnosis Bulletin in 2006. Also a good one for kind of elucidating some of the underlying theory behind the use of this type of approach. And that's it. How did I do? 8:10.
Yes, thank you so much, Dr. Wilson. Anybody who has questions or comments, go ahead and shout them out. Well, I'd like to say that, yeah, what a fantastic way to get the direct staff on board, and like you said, a training tool. I'm not aware of anything. Well, like you said, you can use this for across the lifespan. Yeah, I haven't ever used anything specifically to help me with that problem. And so, yeah, I think I'm gonna get some really good use out of this.
Good, I hope so, and that's what I hope, is that people will create your own format, do what makes sense for you and the system in which you're working. This is what made sense for me. And I think you'll enjoy it, and you'll find it effective. It's very satisfying to work with this tool, I find.
Dr. Wilson, this is Michael.
Hi, Michael.
Good evening. I wanted to ask, has this been used in any school settings? I just see it as a really great kind of summary of a behavior intervention plan. So many times our staff members just they're not read.
Exactly.
Even the best behavior intervention plan, it may be great on paper, but it's not read. But I could really see this being something that could be a supplemental document that we could give teachers that would summarize that behavior intervention plan. I was just wondering if this has been used in school settings at all.
Well, I don't work in school settings at all right now. I have in the past, but since I've developed this, I haven't. So I can't really speak to that. I mean, it's published, it's out there. If people have found it, they're welcome to use it. It would be a great thing to see it being used in school system or in any system. I also use this tool. I meant to upload a slide that demonstrates this, or that as an example of this. I also use it. I do not all the crisis intervention training. I do some of the crisis intervention training at my agency, and I use this tool as part of the crisis intervention training as a model of escalation through stages of crisis. And it works really, really well for that too, where we identify what each individual looks like as they move through the stages of crisis escalation, and how to interact with individuals as they move through those stages. So I think it's so versatile. There's so many things that you could do with it. If any of you are out there working in school systems, I would really encourage you to go ahead and try it and see what you get.
Great. Well, thank you.
You're welcome.
Hi, Dr. Wilson. This is Angela. One comment was, I think it's just great that you reminded us of parsimony with the example that you gave. One client simply went to the doctor, got everything checked out, and then didn't even need intervention. So it's just a really great refreshing reminder that we always have to make sure that we rule out any medical issues. The other question that I had, in the field that I work in, and probably most of the rest of people attending, the level of staff and the reliability and integrity and being able to implement a certain level of treatment. I'm sorry if I missed it. Were you able to conduct that level of reliability and integrity with the staff? And how was that? How high was it? Or
well, I will say that I think that is one of the major issues that you're going to run into, is that you really need to have this investment from staff. You really need to have, the treatment integrity. And I find that the very use of the model, because it invests staff, it does increase treatment integrity. And we will work with staff until they become really fluent in the model. And, they even speak the language. Well, that's a stage 2 behavior, so I should be doing this, that, or the other thing. And we work really hard to get people to that point. And as I said, I'm lucky to have an administration that's on board, because I myself don't have any supervisory powers. So as one of the prerequisites of the model, you do need that investment from staff, that ability to ensure treatment integrity, and an administration that's going to support that. So we have a lot of in-home supervision from different levels of management and administration, and that does help. And there are times when we have to come together and go through it. And I find, so many times I start to see increases in behaviors that I haven't seen for a while. We come together as a staff, and what happens a lot is that people start to do better, and the staff kind of stop following the behavior support plan. So we have to kind of reinvent the wheel and go through the whole thing again. Sometimes I do something kind of tricky when a staff is telling me that everything's gone terribly wrong and that the behavior support plan's just not working and we need to do something. I'll bring them together. We'll do a fresh 4-stage plan. And then I'll pull out the one we did 2 years ago, and they'll see that they're really the exact same. So it kind of demonstrates to them that, had they been doing what was in the plan, we might not have gotten to this point. So I don't know if that really answers your question, but that those are some of the ways that I try to address those issues.
I think that it's an awesome summary way that I think that when I think about using it in the school system, I think that it just makes it so much clearer than all the other pages.
Yes.
And it
Mhm.
makes it easier for the assistants and the general ed teachers, if they're in there, to quickly reference it and know, wait a second, I can just circle this, much clearer than looking at all the pages that are in a behavior plan that we have to share with them. So I do. I
Right.
think it's a really nice way of organizing it to help
Thank you.
people.
Yeah, thank you. Yeah, and you know, by the time you flip through all those regulatory pages to get to what you're supposed to do, if he starts screaming or something, it's you're spending a lot of time doing that. So one page is a beautiful thing. But again, because it's so simplified, you still need that backup, you know, of the whole behavior support. Okay, well, have a great night, everybody. And again, thanks for having me.
All right.
You're welcome. Thank you.